Welcome. So the November MEC Minute is going to be on delayed sequence intubation. We're going to go to this with our protocol in 2020. So we're replacing RSI with DSI for intubating our patients. So for those of you who've looked at the MEC minutes over this past year, you may feel like it's deja vu all over again because we did talk about DSI in May. At that time, I brought it up as a concept. It's something that we'd seen at one of the conferences, and we felt it was something that would fit in well with what we do within MEC EMS. So now the decision's been made. We are going to go to DSI as a substitution for the RSI process, and I want to spend more time talking about it. Before I talked about it as a concept of something we're considering. Now it's something that we're going to use as part of our treatment plan, and it's something that we all need to be aware of, be comfortable with, and train on, because it's going to take a little bit of rearrangement of your thought process in order to do this and do this well. It will also require that you spend time with your partners and mannequins and practice the process. So why are we talking about this? Well, DSI is going to replace RSI in the 2020 protocol. To do this, we're essentially using all the equipment we already have, but we're going to add a PEEP valve, which is an attachment that goes onto the BVM. That PEEP valve costs about $5.50, but we have to have it. And what the PEEP valve does is when you put it on the exhaust valve of the BVM, it puts some positive pressure back onto the airway so that the airways don't fully deflate as part of the expiratory phase between puffs via the BVM. What essentially we're going to do is we're going to put this PEEP valve on the mask, and we're going to provide the patient with CPAP by way of this PEEP valve and the BVM. It will require training to become comfortable with the process, to become proficient at the process, and for everybody to anticipate their partner's actions as we prepare to intubate a patient. So, what is DSI? Well, we're really talking about what we already do, what's already in our protocol. We're just slowing it down a bit, and we're adding a couple steps along the way. So if you're used to quickly paralyzing patient and sliding a tube in, that's really something that we're going to try to slow down so that we can oxygenate or pre-oxygenate a patient before we start the intubation process. So this is an excerpt from our existing RSI policy, and it says we're going to pre-oxygenate via cannula at 10 liters per minute, a non-rebreather mask, or CPAP. So essentially what we're going to talk about is using the cannula high flow via the oxygen supply. We're going to place the mask on the patient's face, and we're going to use the BVM with the PEEP valve to provide continuous positive airway pressure, or CPAP. So we're basically modifying what we've already said we're going to do when we intubate a patient as part of our process. So we're going to take this process, and between the ketamine dose and the succinylcholine dose, we're going to provide CPAP and positive pressure to help oxygenate the patient before we intubate the patient, before we give them chemical paralysis and intubate the patient. So, peri-intubation hypoxia is common and harmful. There have been studies out there that have shown that patients who have traumatic brain injuries, if they have a period of hypoxia and or hypotension in the pre-hospital phase, their outcome from the head injury is worse than if they did not have a period of hypoxia and or hypotension. And the same is true of other conditions. So if you have a patient who's a little hypoxic and then you intubate them or attempt to intubate them and they become more hypoxic during the intubation process, you're hurting the patient rather than helping them. So peri-intubation hypoxia is predictable. We know it's going to occur. It's also preventable, and we're going to talk about that today. That's why we're doing this, is to prevent hypoxia. And we're going to make every attempt to stop intubating hypoxic patients. So before we get into the process, what I would like to do is talk a little bit about why we're doing this, and talk about our oxygenation and how our hemoglobin in our blood is oxygenated when we're normal and when we're sick, with the idea that if you understand this, then I think you'll understand why we need to avoid worsening hypoxia during intubation. So this is what you may have seen in medical school. It's called the oxygen dissociation curve. It basically is an indication of if your oxygenation is 100% and you stop breathing, how long does it take for you to become hypoxic, or how quickly does oxygen get released from your hemoglobin and is able to be released to tissues that need it. So this is the so-called oxygen desaturation curve, and for the purpose of this discussion, the oxygen concentration in your lungs is about 87%. So this curve makes an assumption that the patient has been pre-oxygenated. You and I, with our normal respirations, normal ambient air, has an oxygen concentration about 21%. So most of the rest of what's in air is nitrogen. So part of our pre-oxygen phase is to get that nitrogen out of our lungs and fill the lungs up with as much oxygen as we can. So if you look at the first curve, which is the one to the right, the one with the first red arrow, if this is a normal person, 70-kilo male, and this has been scientifically studied, and if their oxygenation is close to 100%, SaO2 is close to 100%, you'll have about 8.5 minutes before your O2 saturation drops to 90%, and then you steadily or rapidly drop off after that. So that red arrow there is that 90% saturation mark. I think most of us with sick patients would be happy if our patients are 90% or better. So I just arbitrarily picked 90% as the point of illustration. Now, I also want you to take a look at this box on the bottom right. So this box basically is called the mean recovery time after a milligram per kilogram of succinylcholine IV. And where that second red arrow is basically the 50% mark, meaning at just over 8 minutes, 50% of the patients who receive succinylcholine are breathing on their own again. At about 6.5, 7 minutes, about 10% of people, and almost 100% of people given succinylcholine at this dose are breathing again on their own at about 11 minutes. So the reason I point that out is if you look at the normal male, or a normal patient, I should say, a normal adult that has got an SaO2 of close to 100%, before you paralyze them with succinylcholine, at least 50% of those patients are going to be breathing back on their own before their O2 saturation curve dips below 90%. So I'm just throwing that in there for illustration. So on the next curve over from the right is a moderately ill adult, and if this patient's moderately ill and their O2 saturation from the beginning is around 94%, if they stop breathing at that point, they're going to get into trouble. They're going to get below that 90% saturation at about 5 minutes, which is 3 minutes less than the person who is normal and starts out with an SaO2 close to 100%. So what does this mean? It means if you have an acutely ill patient who is starting out at a lower oxygen concentration in terms of their pulse oximetry and their SaO2, they're going to start getting in trouble 5 minutes after you paralyze them rather than 8 minutes with an adult who is otherwise normal. The next curve over is that of a normal child, a 10-kilo child. So we're talking about an infant to a toddler. That child gets into trouble. You've only got about 3.5 minutes before you're going to drop below the 90% mark. And if you have an obese patient, they could be otherwise healthy, but if you have an obese patient who starts out with an SaO2 close to 100% and you take away their respirations, you have less than 3 minutes before they're going to drop below that 90% saturation mark. So, you have to think about that. So if you have an obese patient who needs an emergent airway, we need to hyperoxygenate that patient as much as possible because their oxygen availability, their oxygen concentration is going to drop off much more quickly than for a healthy adult who is at 70 kilos. So why do I talk about this? Because if we're talking again about that moderately ill adult, that second curve from the right, if we can pre-oxygenate a patient and get them from a pre-intubation O2 of 94%, get them up to 100%, they're going to have a better outcome. We're going to have some more time to work. If we develop any difficulties getting the patient intubated, it's going to give us more time. You can also imagine that if patients are starting out on this oxygen curve below the 90 percentile because they have an acute illness for which they are now hypoxic, any improvement we can get in getting that oxygenation curve up, getting it closer to 100%, it's going to be better for the patient as part of the intubation process, and we're going to avoid hypoxia during the intubation procedure. So I want to throw in a study that came out of Texas. This is from Dr. Jarvis and his crew at Williamson County. This has a lot of influence on our making a decision to go to the DSI process. This is a study he published a couple years ago. If you look at on the left-hand side, those lines in blue, this is before they followed the DSI process. And this is a measurement of how many patients, or what were the patients' oxygenations before they were chemically paralyzed with rocuronium or succinylcholine, and then what the lowest point of their oxygenation rate was before the tube was placed. And if you look at this on the left-hand side, which was before the new process, before DSI was implemented, about 44% of the patients became hypoxic at some point during their intubation process. If you look at the red markings on the right-hand side, only about 3.5%, so less than 4% of the patients who were intubated utilizing this new process developed hypoxia during the intubation process. So if you look at it then, as part of the DSI process where we use pre-oxygenation, we get their O2 sat over 93% for a period of time. If we give them ketamine, if we give them rock and then intubate, there's much lower incidence of hypoxia than if we just chemically paralyzed and intubated the patient. So in May, when I talked about this, I throw up two slides or two YouTubes to watch. I want you to watch both of them. The PEEP valve video, which is the second one listed here, it basically has a patient who's had a thoracotomy. The patient, it's a cadaver, but it's a fresh cadaver. The patient's intubated, and they show what happens to the lungs without PEEP and with PEEP. With PEEP, the lungs don't fully deflate between ventilations. It's about a minute and a half. I think you should watch that. It gives you a better appreciation of why we're doing this. The second video, which is the first one on this list, is from Williamson County, and it talks about the process, and it walks you through it. And I think you should all watch that because it's not just listening to me yak on a PowerPoint. I think it's important that you also watch the video to get a feel for how it works. So please watch both of these between now and the first of the year. So this is our new process. This is our new algorithm for intubating patients. So this is DSI, delayed sequence intubation, instead of rapid sequence intubation. So we're slowing things down a little bit, and we have some delays in the steps. So if you look at the clinical indications and contraindications at the top of the page, it is very similar, if not identical, to our existing RSI process. If you're looking at patient prep for intubation, it's also very similar. So you get your equipment together, you get the patient on the monitor, you get the pulse ox and the blood pressure cuff on, and you pre-oxygenate the patient as much as possible, whether you want to use CPAP or a non-rebreather. But this is what you do to help oxygenate the patient before you implement the process. Honestly, for me, I don't think I would bother with CPAP on a patient if you think the patient needs to be immediately intubated on arrival. However, if you think the patient might benefit from CPAP and want to try that first, and then the patient fails treatment and you need to intubate, then you would go from CPAP to the DSI process. So there are some steps to this process. We prepare, we get everything ready. We're going to pre-treat the patient with ketamine, and we're going to make sure that we can use end-tidal CO2 at this point. But eventually we're going to take the capnography device off, or at least replace it as an oxygen source. We're going to use a regular nasal cannula. We're going to put a BVM and PEEP on their face. We're going to have the cannula turned all the way up so it's full flush, and we're going to do what we can to get their O2 saturation over 93%. So after 3 minutes of an O2 sat over 93%, we're going to chemically paralyze the patient. I have a comment in there if needed. So if your patient is going to fight you during this process, then we will give succinylcholine. If the patient's already out of it and is not giving you any airway resistance and you think you can intubate without the succinylcholine, you don't need to use it. And then we're going to, once the patient is paralyzed with the succinylcholine, we're going to establish our definitive airway, which hopefully will be an endotracheal tube. But if you're not successful, you can quickly go to an iGel as your rescue device. So we're going to give a drug, which is going to be ketamine. We're going to pause. We're going to oxygenate. Then we're going to give another drug, which will be succinylcholine. Then we're going to intubate. So let's break this down a little bit. Like I mentioned first, preparation. So everything should be available to you so that if you need it, you don't have to go fumbling through the bag looking for it. So have your laryngoscope out, whether you're going to use the standard laryngoscope or whether or not you're going to use the King Vision. That's your choice. Always think about your rescue device, so have the eye gel at least out. You don't need to open up the container, but you have it out and available. It should be the right size for the size of the patient. I think you should always have the blue bougie available. Whether or not you crack the seal on the packaging is up to you, but it should be right there, so if you need it, one of your partners can hand it to you. We want to get the patient on the monitor, get their blood pressure if we have the chance. We want them on continuous pulse ox and make sure the pulse ox is on a different arm than the blood pressure cuff. We're going to pre-oxygenate that patient as much as possible. And again, if you think the patient might benefit from CPAP rather than immediate intubation, you're welcome to use the CPAP first. That's a clinical judgment you have to make at the time of the assessment. Our next step is we're going to pre-treat, we're going to position, and we're going to pre-oxygenate. So we've thrown some things in here for you. We're going to position the patient, and I'll show you a slide in a moment on that, but we want to get them in position so the anatomy lines up so that when you put the laryngoscope in the patient's mouth, everything's in alignment so you get a better view. One of our first priorities is going to correct hypotension. So if you have a patient who is hypotensive, we will use epinephrine. And this is a bit new for you. So we've always had, or not always, but for the past number of years, we've had an epinephrine drip available to use as an infusion for either bradycardia or hypotension. Well, we are going to now allow push dose epinephrine for patients who are hypotensive. What is push dose epinephrine? Well, it's the same dilution of epinephrine that we used for our epinephrine infusion, except instead of infusing it at 6, 12, 18 drops a minute, we're going to pull up 1 or 2 cc's of this solution and we're going to inject it into, through the IV to bring the patient's blood pressure up. You can repeat the epinephrine boluses or push dose epinephrine as you need to maintain an adequate blood pressure, or if you think it's necessary, you can just plug the epinephrine infusion in and start the drip. How do you make this drip? Well, basically we take a 100 cc bag of normal saline, we take a 1 to 1000 vial of epinephrine, that's the more concentrated vial, and you take the entire vial, which is a cc, and inject it into the 100 milliliters of saline. You now have a concentration of 1 to 100,000. That concentration is what we use for the push dose pressors. It's what we use for an epinephrine infusion. So if the patient is hypotensive, our first drug is epinephrine to get their blood pressure up. Now I say that assuming the patient doesn't need CPR, but if the patient has a palpable pulse but they're hypotensive, we'll use the epinephrine to get the blood pressure up. The second thing we're going to do is going to give the patient a dose of ketamine. And so we're going to give the patient ketamine to facilitate oxygenation. In this case, for this process, our dose is now 2 milligrams per kilogram, either IV or IO. For RSI, it was 1 milligram. But for the purpose of DSI, delayed sequence intubation, we're going to give 2 milligrams per kilogram IV or IO. So you're going to give the patient the medication. We're going to pre-oxygenate the patient. We're going to do that by applying a BVM with PEEP. And with the PEEP valve on, we're going to use 2 hands to hold the mask in place. There's a picture of that. And if the patient needs some supplemental ventilations by gentle bagging, that is called for as well. If the patient is breathing, has an adequate depth and rate of respirations, you don't need to bag them. But if they need assistance, you can do that. When we oxygenate the patient, we're going to put a regular O2 cannula under the patient's nose. We're going to crank the oxygen up as high as it'll go. We're then going to put the face mask on through the BVM. If you need to put an oral or nasal pharyngeal airway in place, you can use that. We're going to have the O2 or CO2 sensor under the mask, but we're going to use the regular cannula to give oxygen because you can get higher flow through it. And our goal is to do this for as long as it's necessary to get 90 or the SaO2, the oxygen concentration, over 93% for 3 minutes. Once we reach that 3-minute benchmark, we'll give the patient succinylcholine. Succinylcholine dose now for intubation has gone from 1 or 1.5 per kilo to 2 milligrams per kilogram. So let's go into a little bit more detail about this pre-treatment positioning and pre-oxygenation. I mentioned we're going to correct the hypotension. So here is the table that's out of the protocol. It's the same table that's been in the protocol for a number of years, except we've added at the bottom of the page in red, push dose therapy for hypotension is 1 to 2 milliliters of 1 to 100,000 solution IV push. So you take a milligram vial of 1 to 1,000 epinephrine, you inject it into the 100 cc's of normal saline, and you will mix it up, and then you can take out 2 cc's for IV push. Honestly, if it was me and I had a patient who was hypotensive and I want to correct the hypotension with push dose epinephrine, I would give them the 2 cc's. If you have a little petite patient and you think 1 cc's that's enough, you can always give the patient more. So that's what we're going to do. That's the first step, is to correct that hypotension. Then we're going to position the patient. So to do this, if possible, we're going to get the head up to about 15 degrees. That helps keep gastric contents in the stomach, but it also helps align the airways. We're going to put a little something behind the lower neck to flex it. We're going to try to get the face so that it's vertical with the horizon, or I'm sorry, parallel with the horizon or parallel to the ceiling. And we're trying to get the opening to the external ear on the same level as the sternal notch. So the face is parallel to the ceiling or parallel to the horizon. It's fully horizontal, and we have the opening to the external ear in line and parallel with the horizon and the sternal notch. And by doing that, once you slide the laryngoscope in, it'll line up the anatomy better so you can get to where you need to go faster and easier. So we got the patient positioned. We're going to give the patient ketamine. So we're going to give the patient ketamine 2 milligrams per kilogram. 45 to 60 seconds later, when the patient is fully dissociated, we're going to attach the BVM with the PEEP valve on it. At the bottom right corner of the slide, it's got a picture of the PEEP valve. And then we're going to start the PEEP at 5 millimeters. You can bump it up to 10 if you think you need it, because the patient doesn't seem to be ventilating adequately. That's a clinical decision you need to make. You use the BVM to supplement ventilations as needed. Again, if the patient is breathing fast and deep or is breathing adequately but just needs help with oxygenation, you do not need to bag the patient. We are going to put the nasal cannula on, and we're going to crank it up as far as it goes. So full flush, whatever your maximum flow rate is on your flow rate is on your meter, that's what we're going to use. So we've got this done, and this is what they call the tower of power for pre-oxygenation. We've got the PEEP valve, we've got the BVM that you can squeeze if it's necessary, but usually you don't. We're going to have capnography in place by way of the sensor. And we're going to use a two-handed thumbs down technique so that one person will have both hands on the face holding the mask in place with the thumbs over the chin. That's going to give us a good seal, and the cannula is at full flush. So I like to point out in this diagram, I misspoke a couple slides back. We're really, if you want to use the nasal cannula for capnography, you can, but once we go to the tower of power, we're going to have the inline capnography sensor that we would use when the patient is intubated. So that's how we're going to monitor the capnography. But this is the setup, and by doing this, we're essentially using the BVM and the mask and the PEEP valve to provide CPAP. And we can hold on to the patient, and we can get them ventilated and oxygenated as much as possible. So we're going to actually have goal-directed oxygen saturation. Our goal is to get this patient oxygenated, and we want to have the patient with an O2 sat over 93% for at least 3 minutes. We're actually advocating now that you use a stopwatch. So, or your wristwatch or your phone. Somebody says, okay, it's 93% or better, let's count the clock. And when it hits 3 minutes, then it's time to move on and get this patient intubated. What's so magical about 3 minutes? Well, like I mentioned earlier, our normal inspired oxygen is 21% of air. By doing this process, we're going to wash out that nitrogen out of the lungs so that there's as much oxygen as possible in the lungs that can be then absorbed and perfused through the patient, so we can delay hypoxia. It gives us more time to get the patient intubated without developing hypoxia in the patient. So we got the patient oxygenated. We've got our 3 minutes in. The next step is we're going to give the patient a paralytic. We're going to use succinylcholine at 2 milligrams per kilogram. We're going to squeeze that BVM every 6 seconds. It doesn't need to be hard, just gently squeeze it. We're going to give the patient 45 to 60, if necessary, 90 seconds to become fully relaxed, and then we're going to intubate the patient. If you're doing this and the patient drops their SATs after you intubate, what are we going to do? We're going to ventilate the patient more. We're going to use airway adjuncts if we have to. We'll abort placement of the tube and we'll place an iGel. If we could really get into trouble, we'll do a crike, but I think that should be unnecessary, especially since we have airway adjuncts like the iGel available. So we want to do this. We want to get the patient intubated. So the next step is we're going to get that tube in. We can use the video laryngoscope. We really don't want to do more than 2 attempts. If we don't get the patient intubated, we should bag them. We get the iGel in, and we just use the supraglottic device, the iGel, to get the patient to the hospital. So we get the patient intubated. What are we going to do next? Well, we're going to sedate and provide routine care, and there's been some adjustments here as well. So we're going to sedate the patient with fentanyl and midazolam. So the first time the patient's getting fentanyl and midazolam is after they're intubated. And then we can repeat this dose times 2 every 20 minutes. We've also added, as part of the sedation and routine care post-intubation, permission to give a second dose of succinylcholine if it's needed because of patient movement. We had a lot of discussion among the coordinators and the EMS chiefs about should we bring rocuronium back, so we give a patient a dose of Sux and then give them a dose of rocuronium, or do we do Sux and if necessary give a second dose of succinylcholine. So we elected to go with a second dose of succinylcholine. It should be safe in all of our patients, particularly if an airway is in place. So having the second dose of succinylcholine is now in the protocol as part of the DSI process for 2020. So what do we do if the patient's already apneic or in cardiac arrest? Well, we follow the process. Our goal is to get these patients oxygenated before we intubate. If we are oxygenating the patient, then getting an endotracheal tube into the patient is not time critical. So follow the process. Yes, it'll take some practice, particularly in a cardiac arrest situation where somebody's going to have to hold the BVM or hold the mask on the face while somebody else bags the patient until they're oxygenated. But for many of us, we have adequate manpower on scene to help do us. So follow the process. Whether or not you use ketamine and succinylcholine for a patient's apneic or in cardiac arrest is your call on the scene. If the patient is in full cardiac arrest and their jaw is relaxed and they're not responding to what you're doing to them, then ketamine and or succinylcholine may not be needed. It's your choice. So if the patient's already apneic or in cardiac arrest, we want to get them oxygenated. We want to follow the process, get the tower of power in place and get this patient ventilated before we try to get an endotracheal tube in. I also threw in here, this is our rule of 2. This was a lot of conversation again with our EMS coordinators. We're trying to keep it simple. So if you're trying to, come up with your drug doses as part of this process, just remember 2. So we're going to use 2 milliliters of 1 to 1,000 or 1 to 100,000 epinephrine. We're going to use 2 milligrams per kilogram of ketamine. We're going to use 2 milligrams per kilogram of succinylcholine, 2 micrograms per kilogram of fentanyl, and 2 milligrams of midazolam. So if you have any doubt in your head, what am I doing? What is my drug dose? If you don't have time or available or access to your protocol on your phone, just remember 2. So again, 2 milliliters of the 1 to 100,000 of epinephrine for hypotension, 2 milligrams per kilogram of ketamine as part of the sedation and oxygenation process, 2 milligrams per kilogram of succinylcholine, whether it's the first dose or the second dose, 2 micrograms per kilogram of fentanyl, 2 milligrams of midazolam, and actually for fentanyl and midazolam, you could also say and 2 more doses if needed. So just remember the number 2 in your head. We have developed a DSI checklist. It is in the protocol. It should be used as part of the intubation process. As part of our review of the protocol, the EMS coordinators and the chiefs both agreed that checklists will be used for DSI as well as for refusal and a couple other procedures that we have in the protocol. We're moving to getting these checklists built into ESO and image trend more to come on that, and that really should be trained to you by your EMS coordinator. So if you have questions about how to use the DSI checklist in Image Trend or ESO, check with your EMS coordinator for the update on that. So this is the process. We think it's a good thing, and we think it's going to make it better for our patients that have to be intubated. But we also have to recognize that there have been some criticisms of DSI bundle, but I think the positives outweigh the negatives. So one of the things is this has been promoted as a bundle of care, so we can't say which part of it is actually the most beneficial. But I still think the bundle shows positive effect, and the information behind this has been published in peer-reviewed journals, so we have a good idea that it works. What value is DSI when the oxygen is normal at start? Well, if I'm breathing normally and my SaO2 is 97, 98%, yes, it's normal for me, but if I all of a sudden stop breathing because somebody gave me a dose of succinylcholine, it's going to take me less time to desaturate if I'm just breathing room air than if I was hyperoxygenated. So I think the value of DSI is it takes all patients and improves their oxygenation before we chemically paralyze them. There's also a discussion about cost of training and equipment, that it may not be worthwhile considering the rarity of its use. Less than 1% of our patients require artificial airways. But I think it's one of those things, it's a high-risk procedure. We are expected to do it well, so we should make every attempt to do it using best practices that benefit our patients. Yes, it will result in longer scene times, but unless you have in a circumstance where you can't intubate and you can't ventilate a patient, there's nothing wrong with taking a couple extra minutes to get the tube in the patient, doing it safely, doing it comfortably for the patient, and not trying to do it while you're doing 40 miles an hour down a bumpy road while your driver of your truck is weaving between traffic. So I think if it takes a little bit more time, so be it. This, I think, is the right thing to do. There's some questions about manpower. So we have some of our agencies that if they have 3 or 4 people on scene, that may be all they have. I recognize that, but I think if we practice, we'll get better at this, and manpower will always be an issue, but we'll be more comfortable doing it with the resources that we have. And then there's some critics across the country, actually across the world, who question the value of EMS intubations in the field. For some people, for some physicians, some EMS experts, there's doubt about its suitability and benefit to the patient. I'm definitely not one of those people. That's why I'm advocating this process. So in summary, we're going to transition from RSI to DSI come the first of the year. You need to practice DSI with your crew members. I'm looking to the EMS coordinators to verify that everybody has practiced this. It's part of the actually, I've got listed as November. It's part of the October. This is the October MEC Minute now, so that you have 2 months to practice it. And then, for some of us like me, the old dogs, we have to be taught new tricks. So there's a lot of readjustment of our approach to patients in order to do this and do this well. So please watch the videos. Again, Williamson County, the DSI video, and then the PEEP valve video. I think they're both worth your while. I think you'll learn a lot. They'll supplement what I have talked about today. So thank you.